Oh, come on. Okay, folks, we're going to do a little talk about short axis view in echocardiography. Hopefully this is working okay. So the short axis view has three main levels that we scan to make sure that everything looks good. The first one is the aortic valve level. Second one is the mitral valve level. And the third one is the papillary muscle level. And what that does is gives the doc a good scan of the heart going from top to bottom. You can also go from bottom to top. It depends upon your lab and what they want to do. So what I would say, I've always gone from bottom to top just because most of the time the most important thing that they want to look at is the function of the LV. And the short axis of the LV is probably the best way of evaluating the overall function of the heart. Okay, so here we have a short axis view at the papillary muscle level. And you can see the different walls of the heart and the papillary muscles. Let me show you the papillary muscle. I'm going to put it in a different color here. So the papillary muscles are here. And those go up and connect to the mitral valve, to the anterior and the posterior leaflet of the mitral valve. I'll show you that in the next view. And those, both the papillary muscle level knows is the best way to show them that you're at the right level to evaluate function. You go too deep, then you're near the apex, and that's not always great, especially if they've had an apical heart attack or MI, then it's not going to work so well. So try to stay at the papillary muscle level. I'm going to give you one quick little trick I learned years ago. If you're trying to figure out what walls you're looking at in the heart, if you're looking at the short axis view, you can kind of put a cross in the middle of it. And this is the anterior wall, this is the lateral wall, this is the inferior wall, and this is the septum. But the septum's easy to figure out because you can see the RV over here. But if you look at it this way, it spells Ali, and I think of the boxer when I think of that. So, and then of course you can cut this even further. You can cut it this way, and then get segments of each wall if you want. So, but for the basic, person who's just starting out, remembering Ali is a good way to kind of get an idea of where the walls are. And here's a shot of the left ventricle at the mitral valve level, and you can see that they've conveniently marked both the anterior and the posterior leaflet of the mitral valve. And then you can also see the interventricular septum, and the RV is on top here. So if you were to separate things, this is RV, this is LV, and this is interventricular septum. And the mitral valve itself, once you get that fish mouth looking picture on the screen, that's what you want to show them. It used to be real important because we would do M mode through that mitral valve. I usually used long axis to do M mode, but it is important just to show them the mitral valve. You don't have to really do anything with it, but if you show them the mitral valve and show them that there's no vegetations or infection on the valve, that's pretty much all you need. So here's a shot of this is one of the Mayo Clinic cuts. This is a short axis view, both the anatomical cut, which really aligns things well. You can see all the chambers and the valves. So, right side, tricuspid valve, RV outflow tract, pulmonary valve, and pulmonary artery. In most short axes, you see the pulmonary artery vessels that come off of the main pulmonary artery. So you have the left pulmonary artery and the right pulmonary artery that come off, and this is left. This is left, this is right. And they come off the pulmonary artery, and most of the time you want to see those if you can, just to show them. It's a good way of showing off or showing them. So, and then you can see all three leaflets of the aortic valve in this view. And, I can give you those. The one over here is the left coronary cusp. The one up here is the right coronary cusp, and the one down here is the non-coronary cusp. So you can see the edge right here. You can see a little outcropping. That's the beginning of the left coronary artery. And if you see this little outcropping here, it's the right coronary artery. So in some cases, they may want you to get coronary flow, or just at least a good look at the coronaries. In children, there's a disease called Kawasaki's disease where you really need to look at the coronary arteries because they can become aneurysmal. In adults, it's not quite as important, but there are people who are doing studies regarding coronary flow via echo, but the velocities are kind of screwed up because you're not very parallel to flow. So they're trying to work on that to see if maybe, if there's a blockage that could pick up the difference in Doppler signals. So maybe with any luck they'll figure it out, and it'll be good. So in the other view, or over here on the left-hand side, you see the the echo view, which is showing pretty much the same thing. You see three leaflets of the aortic valve. You see the right atrium, the tricuspid valve, the RV outflow, and the aortic valve in the left atrium. So it's pretty much really what's important. And then obviously when you use your Doppler signal, you're going to want to sample through the tricuspid valve to see if there's any tricuspid regurg, through the pulmonary valve to see what the velocity is, and then you will look at, I don't recommend it as being a diagnostic tool, but you want to look at the atrial septum to see if there might be any atrial septal flow coming up here in a big flame. It is not perfect. If the ASD is pointing up towards the tricuspid valve, you might see it pretty well, but it's not definitive, so the subcostal is the way to go with that. And in the other two views, you really don't use Doppler in the mitral valve of the short axis view, and the papillary muscle view, you don't use the Doppler. The only time you would use the Doppler is if you had a VSD. In a VSD, what you would see in most cases is flow going across the ventricular septum and into the right ventricle. So here you have the LV, right? And the ventricular septum runs this way, all the way across. And then the RV over here and over here. So it's actually the RV outflow tract, but if you angle back and forth, you see the RV too. So what you'll end up seeing, let me mark this for you so you can see it. What you'll end up seeing is a very high velocity jet that'll be multicolored. So you'll see all these different colors, and it's going through at a very high speed, and that's why you're seeing all these colors. So what you would do is you would take the sample volume and you would run it through that VSD like this using a continuous wave probe. And you can get the velocity, I'm sorry, wrong way. You can get the velocity of the VSD, which does give them a gradient between the, the whole thing, and that can be good. It just depends upon the doc. Some of them like to see the vessels, see the flow through the VSD and see how high it is. Obviously, if you're looking at Doppler, the higher the velocity through a VSD, like let's say this down here was 5 meters per second, that would mean there's a 100 millimeter gradient, millimeter gradient going through that VSD, which means it's very small. Remember, the higher the velocity, the smaller the hole. So that's what you want to see. Now if you see something like this and it's only 2 meters, then that's a bigger hole probably. So you need to evaluate that as good as or as well as possible, and use your 2D imaging to see if you can spot the hole. So not only using Doppler, but spotting the hole with 2D. So anyhow, that's a little extra for you, a little bit of pediatric background there. So anyhow, it's kind of how we do things with the short axis view. We'll call it quits for today, and hope you have a good day.